Welcome to our 31st year of the Race to Erase MS Forum. This is our fall forum. We do another one in the spring. I'm Claudia Curry-Hill, and I've lived with primary progressive MS for over 35 years. And I met Nancy 31 years ago and learned of her vision of a center without walls. And all the doctors you see here today represent various centers across the country of our Center Without Walls program. The Center Without Walls program is funded by the Race to Erase MS, and it has provided support that has permitted the medical community to link together multidisciplinary scientific programs and with the medical community to link together multidisciplinary scientific programs and expertise across the country to advance the understanding of the cause of MS and to develop new treatments. The center is a breakthrough success because of the vision, insight, and flexibility of these extraordinary doctors sitting here. I would like to introduce you to our Center Without Walls program panelists, Dr. Peter Calabrese from Johns Hopkins, Dr. David Hafler from Yale, Dr. Adam Kaplan, Johns Hopkins, Dr. Masad Majid, USC, Dr. Nancy Sykott, Cedars-Sinai, Dr. Rhonda Voskuil, UCLA, and Dr. Emmanuel Wabant, our Race to Erase MS medical director and from UCSF. Dr. Vijay Yadav, Oregon Health Sciences University, and of course, Nancy Davis, founder of the Race to Erase MS. It is my pleasure to introduce Nancy to welcome us.
There we go. Okay. Thank you, Claudia. Claudia has been doing this since I met her so many years ago and putting a brilliant panel together and great topics to discuss and everything for years. I can't believe that I was diagnosed with MS some 33 years ago. At the time, there was no known cause, no cure, no drugs on the market, and very little hope for people with MS. My first doctor that diagnosed me told me I should just go home and go to bed. And I'm like, well, what do you mean? And he said, just go to bed. You'll be able to operate the remote control on your TV set. I'm like, what? I'm 33 years old, and that's what I have to look forward to. And he goes, well, it's better than some. I'm like, okay. And he said, but you'll be able to have people bring you food in your room. So he's basically saying I'm going to live an immobile life. And at 33, I've hit my plateau of excitement and accomplishments in my life. And it was really depressing. So lucky that I was able to go see some of the best doctors in our country and get second opinions. And I was praying that somebody would tell me I did not have MS. Unfortunately, everybody told me I did have MS, but different doctors gave me different prognoses at the time and much more hope that I could live a better quality of life. But what I found fascinating is a lot of the doctors were doing research, but they were doing very much identical research as each other and weren't really communicating. So a light bulb went off in my head. I thought, gosh, I have this really unpopular disease that's never going to have any cure treatments. And gosh, all these doctors, if we could get everyone to work together as a team, we would, be able to find a cure so much quicker by having the most brilliant minds in our country working together. So here we are today in the 31st the year of having the symposiums, and we're going into our 32nd year this coming May of having our Race to Erase MS. And miraculously, there are 25 drugs on the market to help stop the progression of MS. We don't have zero. We have a lot of drugs. We were talking about this yesterday. A lot of people who are newly diagnosed, there's so many wonderful things that you can take when you're first diagnosed that will help prevent your MS from getting much worse. And so this is, it is a miracle. And the miracle is because of all these brilliant doctors I'm sitting amongst. They've all had something to put into all these great stories and great research studies and saving a lot of lives and changing the quality of people's lives. So hats off to every doctor here because they are brilliant. Hats off to also all the brilliant people who are so kind and generous who have supported Race to Race MS for so many years. We could not do it without each and every one of you. And any contribution you make in any way, shape, or form is so greatly appreciated. There's nothing that we do not need, from planning events, coming up with auction items, buying tickets, buying tables. I'm looking at Jacqueline there, who just did a jewelry show at Veronica Beard. Soul Stuff made a wonderful donation to our charity. Each and everything that everybody does is so incredibly appreciated, and I cannot thank everybody enough. However, we have a ways to go. People with relapsing remitting MS are doing pretty well now with the medicines that exist. Not perfect, but better, and they constantly are making these medicines better. But we need to really address the issue of coming up with things for primary progressive and chronic progressive MS, and how we can help remyelinate, restore nerve damage, help people that have different kinds of cases with MS. So we have a very challenged group here. We've been having some conferences. They were here all day yesterday reporting their brilliant studies, and here we are today, and they will tell you about all the science, which I am not equipped to do. But thank you guys for being here, for supporting us, and thank each and every doctor here, because this wouldn't happen without you.
Thank you. And we're now going to begin talking about the topics that we know you'd like to hear about. And at the end of that, we will be answering questions. So if you have any questions, whether you're online or whether you're here and you have some questions that you haven't submitted, please do so. Thank you. So our first topic today is new drugs to slow down disease progression, including BTK inhibitor and simvastatin trial updates. Dr. Emmanuel Baba.
Good morning. Very nice to see you, and you being craving answers to questions, and so we'll try our best to answer questions. We put together these topics, and at the forefront, we wanted to address the issue of progression of disabilities, secondary or primary progression, because it remains really something hard to crack in terms of address with treatment options. And we were very excited because this year there was, so we have two big meetings a year about research in MS. One is North American and one is European, but we travel to those meetings and we share information. The European meeting was a month ago, and there were actually two very important studies that were completed in progressive MS that were actually discussed with the results of those trials. So the first, I'll start with the negative study, right? So I'll finish with the positive. The negative study was a study with a cholesterol-lowering agent, simvastatin, which was used in a smaller study several years ago and was promising because one of the markers that was studied was actually the shrinking of the brain on MRI, and the study was encouraging because it showed the drug slow down the progression of the shrinking of the brain that we know can happen with MS. So as a result, the investigators in England were funded to do a bigger study to see whether there was really an effect on progression of disability and difficulty walking. And that study is actually negative. So this was a pretty large study with several hundred patients with secondary progressive MS, and they were not able to show a benefit in terms of progression of disability. So that was a downer, but now there's some uppers, right? There are a new category of medications called BTK inhibitors, and you probably have heard a lot about them because everybody is excited when there's a new strategy to try to address treatment of MS. There were several studies that were done in relapsing remitting MS, and one of my other colleagues is going to talk about those. And I'll address just the one that was announced in progressive MS. So that study is positive. It was done in a large number of patients, again, several hundreds of patients. And one of the questions I have here is about, what about tolebrutinib? And that was actually the drug that was tested in that large study. The study showed that there was a 30% reduction in the progression of disability compared to a placebo. And to put that into perspective, the only drug that is on the market now that slows down progression of progressive MS is Ocrevus, and that medication is known to decrease progression by about 25% on average. So we're in the same ballpark here. I wouldn't say that one is superior to the other. I would say that we're in the same ballpark, and Roche is actually doing a trial comparing Ocrevus to their own BTK inhibitor, and we won't have the results probably for a couple of years, I think. So I don't expect one will be superior to the other, but at least it's very encouraging that we will likely have another drug approved within the next year. The caveat with the tolebrutinib, so it's an oral medication, it's a pill you take every day. There was a small proportion of patients who developed some severe liver damage with the medication. The trial was helpful in that the risk of liver damage was known, but it was the timing of that to happen was not very well understood with the small study, but now with the big study, it's clear that you have to be monitored very carefully during the first 20 weeks, I think, of the treatment to make sure there's no major liver damage. So stay tuned, because it's very likely in the next year there will be that second drug for progressive MS that may be FDA approved. Very exciting.
Thank you, Dr. Wava. And next we have results of a new clinical trials in relapsing MS, including, we just did that. So next we have new immunity updates in MS. Dr. David Hafler.
That was.
Oh, I'm sorry, we did. It sounded the same, yes. Thank you. Yes, I'm skipping. Results of new clinical trials in relapsing MS, including BTK inhibitors. Dr. Masoud Machine.
Hello, everyone. Thank you for the invitation. It's exciting to talk about new medications in MS. And as you know, MS has two phases that can happen together or alongside each other, the relapsing phase and the progressive phase. In relapsing phase, it starts with dysregulated immune cells that enter the brain-blood barrier and cause inflammation in your brain, make demyelinating lesions, and then those cells together with the immune cells that you already have in your brain and the glial cells, including microglia and astrocytes, cause a compartmentalized inflammation and degeneration in the progressive phase, which is much more difficult to get access to and treat. But in the relapsing phase, we just need to address those dysregulated cells in the peripheral immune system. And as you know, we have really good medications already for those. The depleting B-cell treatments and natalizumab are very, very good in stopping that process. To the point that with B-cell depleting medications, the rate of having new lesions in the MRI is less than 5% each year, which is tremendous, which is really, really good. And we have rituximab, which is infusion every 6 months. Later on, we found Ocrevus infusion every 6 months, Kesimpta injection monthly. And 2 years ago, we found there was another medication that was added to the mix. It's called Briumvi. It's another infusion every 6 months. But they, of course, they're very effective, but still flares can happen with B cells. And one issue that we have with B cells that now, as we use them more often, we face it, is that prolonged use of these medications increases the risk of certain types of infections, such as urinary tract infection and pulmonary infections, basically. So they still have some challenges, and there's some new trials going on and changing the way we give these medications, such as extending the interval. But of course, there are other medications have been tried. As Dr. Bobman mentioned, the BTK inhibitors are very exciting because BTKs are not only involved in signaling pathways into cells that are involved in progressive phase, such as microglia and macrophages. They're very important pathways for maturation of the B cells themselves. So blocking them can help with potentially can help with the relapsing phase of MS as well. So the clinical trials was done on relapsing phase of MS as well. The same medications that was used in progressive MS but have been tried in relapsing MS. Two of them has been moved to phase 3. Tolebrutinib and evobrutinib have moved to phase 3, and results of them have recently been published or presented in MS conferences. Tolebrutinib was studied in Gemini 1 and Gemini 2 study, and it was compared to Aubagio, which is the standard treatment we use for MS. And the study didn't show any significant difference in relapse rate between Aubagio and Tolebrutinib. Unlike the studies on progressive phase, there was a significant problem with liver enzymes, especially in the first 3 months. About 5% of patients had elevation of liver enzymes, and 1 in 200 of patients had dangerous level of increase in liver enzymes. So checking the liver enzymes while you're taking these medications weekly in the first at least 3 months is needed, and that's what this study is doing. The other medication that was studied in phase 3 was evobrutinib in 2 studies that was called Evolution 1 and 2, and the result of them was published last month. And it's same-wise, it showed that there was no difference in relapse rate between evobrutinib and Aubagio, and again, liver enzyme elevation was a problem. So overall, it seems that BTK inhibitors might be a real good option in future for clinical use in progressive MS, but they might not be the most potent medication for relapsing phase of MS. One other medication that this year was published that was studied in relapsing phase of MS was frexalimab, which is an antibody against CD40 ligand. CD40 is a marker on B cells and many other antigen-presenting cells that when it binds to its ligand and T cells, it can activate many innate and adaptive immune pathways that are involved in MS disease and MS relapses. In a small study, the study group compared frexalimab with placebo, and they showed there was decrease in the amount of GAD-enhancing lesions, but we need bigger study on that medication and comparing with standard treatments in phase 3 studies. So overall, it seems that despite of all these new trials, B-cell depleting therapies are the most effective medication and most potent medication for prevention of relapses. But we need to find some strategies to limit the side effects with prolonged use of them. And here I think we have questions about stem cell treatment for MS. So, before doing the B-cell treatments, there was a lot of excitement about stem cell treatments and use of them, especially early on in the pediatric population. The patients that I've seen, when we use the B-cell depleting treatments, they're very, very effective in preventing MS. And of course, the stem cells can help with that, but they do have side effects. It's not using stem cells would be without side effect. The risk of some malignant, some hematologic malignancies, risk of infection is much higher than B cells. And because B cells are very effective and the risk is less, at least I try to use B cells. And if the patients fail through the B cells, I have sent some patients to the clinical trials of hematologic, like autologous stem cells, only in the patients that failed B cells. And in my patients that I've seen, I just have done it 2 times that I refer the patients to the trials. Otherwise, if the disease is aggressive, I try to use the B cells for prevention of relapses. Thank you.
Thank you, Dr. Majid. And next, new immunology updates in MS. Dr. David Hafler from Yale.
Thank you, Claudia. Let me start by asking a question of the group. Who here thinks we know the cause of multiple sclerosis? Raise your hand. Nancy, good, thank you. Anyone else? If Howard was here, he'd raise his hand. Yeah. So it's a trick question because you never truly know causality because you don't know what you don't know. But we have a very good working model for what causes MS. And the way we validate the model is by doing clinical experiments where we do interventions in patients and see if it works, and if it does work, provides evidence for the model. So what is our working model? I think for most of us in the field, we believe, we know that MS is a complex genetic disease, and we can talk about that later in terms of some of the questions that were asked. But to get MS, you have to have the genetic background. You will likely not have a family history, but you'll have many common variants which affect the immune system and lower the threshold of activation of the immune system. Then with a environmental event, and it's probably Epstein-Barr virus, you then trigger myelin reactive T cells, which then traffic from the circulation to the brain, recognize myelin antigens that cause the disease. But for that to happen, you have to have a loss of regulatory T cells called Tregs. And it's been shown that these cells are defective in MS. In fact, virtually all autoimmune diseases. So you have a combination of genetics with some environmental event, and the other environmental factors include smoking, childhood obesity, high salt, but then you induce these autoreactive T cells. Now, how do you provide evidence for that? What's new in immunology? So we've heard about B-cell therapy, which is just incredibly dramatic in terms of what it does. I mean, right now in our clinic, if you have early relapsing-remitting MS and don't respond to B-cell depletion, I mean, it's not really depletion. You deplete the cells in the blood, but they're still in your body. They're still in the lymph nodes, but decreased. If you don't respond, we start looking for other autoimmune diseases like sarcoidosis, lupus. That's how frequently, how rare non-responders are. So we did an experiment. We asked, how does a drug work? And involved a new technology. We take each individual single cell, we interrogate it. We had no hypothesis to begin with. I believe in hypothesis-driven science. You start with observations, then you generate hypotheses. And what do we discover? Turns out that B-cell depletion leads to increases in regulatory T cells, they markedly increase in frequency and number, and associated with a loss of myelin reactive T cells in the circulation. So does that prove that our model is correct? No, but it begins to provide more evidence that autoreactive T cells, recognizing myelin antigens with loss of immune regulation, is what's causing the disease, and B-cell depletion corrects those defects. So that's sort of very exciting to me. The paper's under revision, sent it back to the Journal of Clinical Investigation yesterday, and hopefully the paper will be coming out soon. So I want to just come before I forget about stem cell therapy. I want to make sure we know by what you mean by stem cell therapy. I get a bit unhappy with the use of stem cells. So there are stem cells. We use stem cells to treat certain diseases of the eye, where you actually do stem cells which regenerate into working cells in the eye. That's not what we're talking about in MS. It's bone marrow transplant, where you take the bone marrow, you give a toxic dose of chemotherapy, deplete the immune system, and you rescue the immune system with hematopoietic stem cells. So that's what people mean by stem cells. It works really well, as does pulse cytoxan, but it's a very, as was pointed out, it's a very dangerous treatment. And we actually haven't done it. We're prepared to do it. We haven't done it because the other therapies work extremely well. So I'll stop there. Thank you.
Thank you, Dr. Heffler. And next we have wellness intervention, exercise, diet, and restoring function by Dr. Vijay Yadav.
Hello, everyone. Good morning. And before I begin, I want to say thanks to Nancy for her vision and for her, thought about having this forum each year, twice a year for all of you, so that we can share the latest in our knowledge about MS. I think, and she has been doing that for the last 31 years, which is amazing. And I think to bring all of us together, it is really kudos to you and hats off to her. So in terms of who am I? I am one of the professors of neurology at Oregon Health Science University in Portland, and my research interests have been looking into complementary therapies of MS and also looking into wellness interventions as well as lifestyle interventions for MS. That's a topic which is very close to people's heart. And because medications or the drugs that we use for MS, like disease modifying therapies, I think all of us are pretty comfortable using them. There are guidelines, there are the FDA approval label says everything how to use those drugs. But the things which are not really very well clarified is how do you utilize these strategies which can improve health. There are no good guidelines on improving health, for example, like how to utilize complementary therapy or supplements or exercise or diet. So there are small research, but there's no good guideline to really incorporate those into our patient's life. So we really pay a lot of attention to what the people are asking for. One of the things which people are really intrigued by is what can they do themselves to improve, MS and their quality of life, and that's really important and should be important for pretty much every MS patient. So in terms of what we have learned in the last several years, definitely the role of diet is not very clear yet. What we have learned that diet can definitely improve, or certain diets can definitely improve certain symptoms of MS. For example, fatigue is a very common symptom in MS patients, and there are small trials, but all of them are showing that you can improve fatigue if you eat a healthy diet. And when we say healthy diet, it can be anything. Some of it is low-fat diet, some of it is Mediterranean diet, some of it is even like intermittent fasting type of diet. So all of them are showing that there can be a significant role of diet in improving especially the fatigue symptoms, and maybe the mood as well as like cognition to some extent as well. How does it work? We do not know that yet. So I think that's the next step that all of us are working towards. How to understand like how the diet may be affecting different aspects in the human metabolism, and how it can really become a part of MS care. So I think those things I feel very promising. And the role of gut microbiome is directly connected to that, because if you look at the diet, that's one factor which impacts the gut microbiome the most. So that diet and how that changes the microbiome, they are directly connected, but we still do not understand how that whole thing happens. If you look at the gut microbiome, that's probably the biggest factor of immune system in the body. I mean, gut is where the immune system develops, and things happen, and even bad things will happen because of the gut dysfunction, gut microbiome dysfunction. And can we change that by using probiotic? We do not know that. I mean, there are in drugs also, the disease modifying therapy I probably have impacted the microbiome, gut microbiome as well, but we still do not understand how it is changing overall. So should we take probiotic? I think the answer is not very clear. So I would say eating healthy probably is the best way to improve your gut, and also taking the medication which the doctors are prescribing probably are the best way to manage at least relapsing MS for sure, instead of focusing on other things. Supplement role is also not very clear. We have looked into antioxidants as supplements. For example, lipoic acid is one of the or over-the-counter supplements, which we have been looking into for some time. So it has shown very promising results on kind of protecting the brain volume or preventing the brain atrophy. But it did not really show any significant change on the outcome. For example, mobility or the overall function did not really change in the 2-year trial, but it did show consistently that it is protecting the brain atrophy. How much should you take of lipoic acid? The dose which was tested in the clinical trials was 1200 milligram per day, and it can be taken with food. There was a question about whether a racemic form of lipoic acid should be taken, or is it better than the regular form, which is usually the mixture of R and S forms of MS. So there's no data. We were using the combined form, which has both R and S forms of lipoic acid in the clinical trial. So at this time, R lipoic acid by itself is not really needed because it's more expensive. And so I think that's something that was one of the questions here. In terms of other factors, what else should we do besides diet and supplements? And supplements, vitamin D is something which we definitely pay attention to. That's probably one supplement that would be needed if somebody is deficient. And majority of the people, because of our lifestyles, which is mostly indoor living, people are deficient. I mean, I think probably if you look at US people across the world right now, I think vitamin D deficiency would be probably the most common deficiency. So that's something that can be easily tested by a blood test and optimized. We are not recommending that you should be taking the vitamin D to have a very high level of vitamin D. It should be a lower to the mid range of vitamin D levels should be enough to provide the benefit that it's supposed to provide. The last part I would just kind of emphasize would be the role of exercise and just any kind of movement activity that people should be doing. Really important for people who are losing function, like people, because as we know, some of the MS patients, even though we have the medications available, they will continue to lose function because of the disease progression. They should be working actively with their physical therapist, with their exercise trainers, or anything that they can do to maintain the function. One of the things about MS is if you become less mobile, you will also lose muscle mass because of the entity called sarcopenia. So sarcopenia itself, with aging, sarcopenia is much faster. Younger people will not really have as much muscle loss, but as we all get older, the muscle loss becomes much faster. So that's a very key role that progressive patients can have. That you can maintain by doing exercise. Any form of exercise, there's no limitation to what one can do. Anything can be pushed. So we no longer recommend that people should be resting and not really doing exercise, because exercise can potentially, there could be a role of maybe remyelination of, from exercise. So those things should be done. And working with a trainer, I would say, is the best way. Working with a therapist is the best way. Working with the doctors is the best way to learn what the best technique would be for any of you. So I think I'll just stop that.
Thank you, Dr. Yadav. So next we have Dr. Peter Calabrese from Johns Hopkins with new diagnostic criteria for MS. And we will be answering questions after all the topics have been discussed. Thank you.
Hey, good morning, everyone. Thanks so much for coming out on a Saturday. It's great to see everyone. This is like one of my favorite parts of coming out to LA is seeing everyone. We have any Dodgers fans here? Yeah. Woo! I'm from,
Did they move from Brooklyn yet? I'm checking.
I'm from Baltimore, so anyone who beats the Yankees is okay with me. So I'm going to talk a little bit about the what we call the McDonald diagnostic criteria. And your first reaction might be like, oh, you guys don't know how to diagnose MS yet? And the reality is that specialists, around here, we're pretty comfortable, but over 90% of people with MS are actually seeing non-specialist neurologists out in the community. So it's really important to provide specific criteria so people are diagnosed early and can benefit from therapies, but not get misdiagnosed and get exposed to the risk of therapy. So every 6 or 7 years, a group of experts, and I was fortunate to be part of that panel this time, get together and decide whether there should be any updates. And it turns out that there were several areas that really needed updating. The first one was that, believe it or not, the optic nerve, that nerve that transmits visual information from the back of the eye to the brain, was not considered a formal location for MS. And we all know that that's actually kind of silly, because about 25% of people will present with optic neuritis and then end up having MS. And so it seems to me that was kind of a bit of an oversight. But I think the trick is, I was thinking that, no pun intended. But it's important to know that actually around the world, not all cases of optic neuritis end up being MS. In fact, there are about 60 different kinds of causes of optic neuritis. So it is important that even if you have optic neuritis, that you do the rest of the MS workup. But what's new is that we have better tools for seeing classic MS lesions in the optic nerve. So one of them is just new kinds of MRI can actually see these lesions better. If you have a conventional brain MRI, you might miss the tiny little area of demyelination in the optic nerve. So there are special MRIs called orbital MRIs that we can use that are more sensitive for picking up optic nerve lesions. Another tool is something that near and dear to my heart. We've been using a technique called optical coherence tomography, or OCT, for the last 15 years. And this is a device that actually measures how much thinning or damage that there is in the back of the eye that we call the retina. And after an optic neuritis, you might know that the eye doctor or your neurologist can use an ophthalmoscope and see changes in the back of the eye. It's sort of a subtle change from pinkish yellow to a more pale color, but it's very hard to quantify. So this machine, the OCT, can actually put a number to it and tell you in micrometers how much thinning has occurred. And if there's a certain amount of thinning, then and it's asymmetric from the other eye, we can infer from that there has been an event that's probably optic neuritis. And of course, finally, there are older techniques like something called visual evoked potential, which measures the electrical conduction of that signal. Those are tricky, and not so many centers do that anymore, but for centers that have visual evoked potentials, it's also another way of documenting optic neuritis. The other major change incorporates MRI, and I don't want to steal thunder from Nancy Saigot, who's been very much involved in this, but there are two tools, one called the central vein sign and one called phase rim lesions or paramagnetic rim lesions that add specificity to diagnosis of MS. So you may know that lots of people have white spots for a variety of different reasons. You could have migraine headaches, you could have prior head trauma, but the spots in MS have certain locations, and so that can be helpful. But even then, we're not always sure. And so if you see a central vein inside that spot, it turns out it's much more likely to be MS, because we know from pathology studies that that's the underlying basis. That's how the immune cells get out of the blood vessels and into the brain, is through these veins. And so if you see a vein in the center of the white spot, it stands to reason that it's probably MS. And the phase rim lesions are interesting. Those have not been as heavily incorporated into the new criteria because we're still kind of debating exactly how to be sure that one exists. But we call them PRLs for short, PRL. They are iron around the edge of the lesion, and pathologically they tell us that that lesion is likely to be a chronic active lesion. And I think this is going to be really important, less so for the diagnosis and more for figuring out where people are in terms of progressive MS. And the more PRLs you have, the more likely you are to become disabled, and maybe someday we'll have therapies that will either prevent them or make them go away more rapidly. So those are some of the changes. I think it's exciting. It's a big step forward, both in terms of improving our ability to diagnose MS early. In fact, there is a syndrome that we call radiologically isolated syndrome, where someone may have gotten in a car accident, bumped their head, someone gets an MRI and sees classic MS lesions. But there was always some concern, like, well, is that person really going to get MS clinically? And now the answer to that is, if you have all these other criteria, it is very likely, and it seems silly to wait until you have a clinical event when you already know someone very likely has MS and could benefit from treatment. So this will be published probably sometime early next year, and then there'll be a series of educational events to make sure people out in the community kind of understand how to apply these criteria and make the right diagnosis early so people can get on therapy. Thanks very much, and I'll save my questions for the end, as Claudia indicated.
Thank you, Dr. Calabrese. Next, Dr. Rhonda Vasco will talk to us about family planning for women with MS.
Thanks, Claudia. Well, women are affected by MS. It's 3 to 1, women to men. So I am going to focus on women for this small section. The things we want to think about are with family planning. Of course, the first question is, some women are scared to have kids and couples because they worry about the genetics. It is a genetic disease. It's a very polygenetic disease. It's over 100 genes that contribute, and it's not, necessarily going to confer that your child is going to have MS. The probability of risk might be increased a little bit, but again, it'd be on the order of things like Alzheimer's or lupus, and actually a lot of immune genes. So that isn't the kind of thing that make people not have kids. I mean, it's one of the best things we can do, and just feel comfortable knowing that the incidence might be increased a tiny bit just because you have genetics in the larger family, the family at large, but that shouldn't. Well, you can do what you want, but I would say, it's not that they're necessarily going to get MS. Let me put it that way, at all. So feel free to go ahead and, do family planning with that security and information in mind. The other thing that's the good news about pregnancy and MS, actually the children, they're normal. The birth, the delivery, these things are normal. There are a few caveats if you have a certain particular disability that's quite bad, but by and large, it's safe to be pregnant and have kids. It's a good thing, so I wouldn't let that stop me either. And then you also start thinking about birth control pills, oral contraceptives. Do they increase the risk to get MS? The answer is no. Do they change the progression of disease activity in MS? The answer is no. And the reason for that doesn't mean necessarily that estrogens, for example, don't play a role. The thing is that the studies with the oral contraceptives have used all different kinds of doses and timing, and some of them don't have estrogen at all. So the thing is, the data show that oral contraceptives don't have any effect on MS, so you should feel free to take them or not take them as you wish for the rest of the other parts of your life, and don't worry about that. Now, the next thing is pregnancy, which is the big part of family planning, the biggest part. So we went to before, I'm going to go to before, during, and after, so it's a kind of a chronological review. So without being too long, the pregnancy, of course, once you do decide to get pregnant, and that's great. The thing is, it's not that estrogens can't have any effect, because we all know now that pregnancy is really good for MS, and it really correlates with, you know, the last half to the last trimester. Women feel they're over 70% likely to have a relapse. They feel great, and so this is a really good time for their MS. And of course, that's when these estrogens, there's two estrogen, estradiol, the menstrual cycle, and also estriol. The estriol is the one unique to pregnancy. These things go very high, very low, very high. The third trimester, when you're really protected, and then when you deliver, it drops like a bomb. And there are postpartum relapses that can come in the 3 to 6 or 3 to 9 months after delivery, probably when these hormones wash out. And so, but then people tend to equilibrate back to baseline with the pre-pregnancy rate. When they are about a year or so after pregnancy, the relapse susceptibility tends to equilibrate back to baseline. The thing, though, that is also important is that more than just temporary relapse reduction during pregnancy, multiparity, having, for example, 3 children or more as compared to having 1 or 0, multiparity is actually good and has been shown in some reports to be good in the long run for chronic disabilities. That means there could also be not just an anti-inflammatory effect, it could be neuroprotective, because you've got this multiparity that's being protective in the long run about having less disability. And it's not just a selection bias, because some studies have control for that. About, you would say, oh, well, the women who have more disability don't have kids. But there have been studies done with these very early phases that imply that it's not just that. It looks like pregnancy can be protective in the long run. So those are all good things. The things people obviously worry about is, the postpartum relapse. And I think that other than telling women not to become pregnant and have kids, again, I don't think that's the answer at all. I think the answer is you need to be ready and prepared for when that might happen, and make sure that, your partner is on board with, we're going to have help, and other support systems, actually. But the bigger question is always the disease-modifying drugs. And so I don't want to get into every disease-modifying drug. There's a lot of data on which ones you can take more safely, less safely, and you really should have that discussion with your OBGYN as well as your neurologist about your particular situation. I will tell you, though, one thing to always keep in mind is when and if you do need to or need to go off of these DMDs for the pregnancy, for the baby, so there's no exposure. For some, more important, obviously very important for some, not so much for others. That's a discussion, but you always need to keep in mind what's your pre-pregnancy relapse rate. So you tend to have a lot, and maybe you're on a DMT, and so you're not having any, but you have a pretty good feel for what your relapse rate might be like if you weren't taking a DMT. So you have to think about that. That's the most important, because this is what, you were worried about could happen postpartum, of course. And then breastfeeding has been talked about. Is that protective? It's okay to not be on a DMT because of when a breastfeeding. Breastfeeding is great, but I'm not convinced at all that breastfeeding is like a DMT. I'm just telling you, there's some data that show that, oh, well, maybe breastfeeding might be helpful for the postpartum relapse, but some of the data was just you had to do exclusive breastfeeding. That means absolutely nothing else, and partial wasn't. And so I would not rely on breastfeeding to be my DMT postpartum. I would think very hard about when I wanted to resume the pre-pregnancy DMT. And then I guess last of all is, after all the pregnancies are over and we start to go through something called menopause, which is relevant to towards the end of my talk and the end of the later part of life, the later part of my little talk here, is with menopause, that's bad for MS. So with menopause, bad in what way? They don't start having relapses, but what they do is their pre-existing disabilities are thought to get worse. And so that's probably because of loss of this neuroprotective estrogen. And we're now working at UCLA on treating with an estrogen. It's the pregnancy estrogen, actually, because it binds the estrogen one receptor in the brain that is different than the one that binds so strongly to estrogen receptor alpha in the breast, because we're all worried about breast cancer because it's very common. So there's this opportunity between how can you have brain protection with an estrogen and give it at a dose and a duration that's appropriate for brain protection, and not expose yourself to an estrogen that binds so strongly to estrogen receptor in the breast. So it's maximize the efficacy and minimize toxicity. So that's what we're doing for menopause, and that again, estrogens are not all alike. It depends on dose, timing, type. It's got to be optimized. Birth control pills have no effect, and maybe if you get the right dose, timing, and so forth, you can have a good effect. And recapitulate pregnancy would be the goal.
Thank you, Dr. Voskuil. And now from Cedars-Sinai, Dr. Nancy Sykott will speak to us on new MRI markers for MS diagnosis and prognosis.
And thank you, Nancy. And also I want to thank whoever put the heater right in front of me. That was fantastic. So I do want to just acknowledge how great it is that we come together twice a year and we talk about progress and we think about the future. And Nancy, I think, set us up nicely for where we were when she was diagnosed and where we are now, which is in a much better place. And now we're starting to think about things like how can we prevent progression, which, was something that I don't think we thought about in the beginning. But how did we get here? And that's actually a team sport. And I think you can see from the different subspecialties and areas of expertise around the table that it takes a village to move from the basic science in the lab to a medication that we can then safely give to patients. And one of the big innovations that helped us get there is MRI and other biomarkers. And I just want to acknowledge Henry McFarland, who is no longer with us, but was on the scientific advisory board for many years. And I know Nancy worked really closely with him. He had the vision, he was at the NIH, he had the vision to think about using this somewhat new technique that was available called MRI to really understand MS. And, for those of you who live with MS, this is a disease that evolves over not minutes and days and weeks, but months and years. And that makes it really challenging to test therapies to see how well they're working. So it could take, 3 years to see an effect on relapses. But what Henry did, he realized that MRI, and especially contrast-enhanced MRI, could give us a biomarker for relapses. And so we could look at drugs and look at the effect of drugs on those enhancing lesions, which could then take a study that would be months instead of years. And it was really this innovation that moved the field forward so that we now have 25 drugs. And all of those drugs have been shown to have a benefit on decreasing these enhancing lesions because they're a really good marker of relapses. So that's where we were. Now we have to go to the next level. What are those MRI markers that are going to help us understand the big challenge we have now, which is progressive MS? So we know that our therapies are really good at getting rid of those enhancing lesions. And in fact, MRIs don't seem to really change much after we've had a good effect on that. But we know our patients continue to have worsening symptoms, difficulty walking, and we don't have a good way of understanding why that's happening. We don't have a good biomarker, although we're starting to make some progress. So you heard Dr. Calabrese, who talked about these pearl lesions, which we think are very promising as a potential marker for future disability. And these are, as he was describing, these are iron-laden macrophages, so a certain cell within the brain that is responsible for some of this activity that we're seeing. So we think it's a different process than what we're seeing with the gadolinium-enhancing lesions. And we're using MRI to try and track those lesions and see, once we have a good understanding of those lesions, then we can look at our therapies and see, do our therapies help? Do they help with the pathological changes that are driving progression? So this last year, we had, as you heard, the new diagnostic criteria for MS that included something called the central vein sign, and the scans that we do to see the central vein sign also give us some visibility to these pearl lesions. But I did want to acknowledge Nancy's role in bringing this central vein sign to the diagnostic criteria, because it was this group that started NAMES, which I represent as part of the centers, which is North American Imaging and MS Cooperative. And that was one of our big projects, was to look at this biomarker called the central vein sign. And thanks to Nancy's support and the foundation's support, NAMES is now over 35 centers. But one of our achievements has been bringing this new biomarker to the diagnostic criteria. So I want to thank Nancy and all of you for all you do, and look forward to the next challenge, which is tackling progressive MS. So thank you.
Thank you, Dr. Saka. And last but not least on our topics is health information technology and mental health with Dr. Adam Kaplan.
Thank you so much, Claudia. I'm going to actually change the topic a little bit because I'm in the process of working with some people to try to start a new pharmaceutical company devoted to finding new treatments for cognitive impairment. And because MS is, at the center of my concerns and interest, it is something that we're spending a lot of time on. And this is an interesting presentation for me because it may very well might, during the question and answer period, generate discussions among my colleagues where they might disagree, because they're entitled to be wrong. No, I'm just kidding. They're different opinions from different people. But the question is, everybody here should know that there is some question as to what MS is in terms of, is it one disease or two diseases? And what do I mean by that? Essentially, you probably have heard about secondary progressive and this concept of progressing in your multiple sclerosis. And essentially, there's three scenarios that people talk about. One is that inflammation occurs, that then leads to an effect that has short-term but also long-term effects. What I tell my patients is, and it's a metaphor because obviously, this is not, we're not made of rubber, most of us. And so, you've got wires, and if you remove the insulation from the wires over time will rust. And that's what I tell patients is the reason why you want to stop the inflammation, stop the attacks, is you don't want the rusting to occur down the path. Other people believe completely the opposite, that there's this rusting process that happens, and then the cells come rushing in and say, wait a minute, this is damage that's happening and we have to stop this. And that's where the immune system kicks in. I really don't think that anybody here would say that that's what's going on with MS, but there are people who believe that. And then there are people who say that there's two separate diseases. One is the inflammation, but then there's this other process that goes on that's completely independent of the inflammation. And so, that we need two separate treatments, which arguably we need two separate treatments, but the question is, could you stop it at the beginning? So let me just try to present a way of looking at it. The first thing is, why do people have this confusion? They have this confusion because when you see patients who appear to not be having active, attacks, and then they get worse, sometimes, suddenly over time, and it's just, there's nothing we can do to shut it off, and we've tried everything that we can think of for the existing treatments, as a prelude to why we're trying to come up with new treatments in this area, then it looks like there's a separate process. But as my colleagues have been pointing out really clearly, what we see is the tip of the iceberg. And so just really briefly, we know that 80 to 90% of MRI lesions that take place in relapsing or remitting MS are happening under the radar. We don't see them. And if you do serial MRIs, you'll see that many of these lesions happen and we just don't see them. And people don't feel them. They're not in high real estate areas. But we've heard about pearls, and that's in 20 to 30% of people with relapsing remitting MS, and that is an indication of ongoing inflammation. And there's cortical lesions, meaning just not in the wires, but the actual storage places for the information in the brain. And we know that looking at microglial, which is the immune system of the brain, it gets activated in 30 to 40% of people with relapsing remitting MS, and you don't see it unless you actually take some radioactive tracer and put it into the brain and see it. So there's all this stuff going on that we don't see, and when you don't see it, it's easy to say, gee, there must be some, thing happening that's independent of this. So let me just present, and this is, the last thing is just what the evidence is, I think. The first thing is, the good news is, and, Nancy appropriately stresses this, is that having put people together in Center Without Walls and having the collaboration of so many of the, brilliant researchers in MS and people who are here has made a tremendous difference. So, for example, these highly effective disease-modifying therapies, not the ones we had at the beginning, but now that are much more effective, have decreased the rate of brain atrophy by 2/3. Okay, so the brain shrinkage can now be blocked by 2/3. Of course, what have you done for me lately? What does that translate to? What that translates to is that if you start these highly effective treatments, within 2 years of the disease onset, you will decrease this progression. You'll actually not have progression as worse, and you won't convert to this secondary progressive where you're just getting worse independent of these things by 34 to 47%. You will decrease that. And what that translates into is in the 1990s, 50%, we would tell people 50% of people within 10 years are going to go into this progressive disease for which we have no good treatments. And now we can tell people it's actually only 25%. Why? Because we have better treatments. Are these treatments neuroprotective? As Dr. Voskuil is working on neuroprotection, which is critical because once you have the damage, you want to try to restore or protect, prevent the rusting. But no, what we have now is blocking the inflammation is decreasing by 50% the progression. What I think is most compelling, though, and Dr. Calabrese and I and Dr. Hafler earlier in his career were involved in doing research where it was stem cell transplants. And that's not for the faint of heart. Stem cell transplants have a mortality associated with them. It used to be 1 in 10, and then it went to 1 in 100, and now it's probably 1 in 500 people will die as a result of getting some terrible infection. So not for the faint of heart, but what we know from these studies in a review paper that came out of 5,000 people in 50 studies is that 70% of people, you will completely stop progression, you will completely stop the new attacks by resetting the entire immune system. So you watch someone's white blood cell count go to 0 and a new immune system will come. So 80%, you will stop 80% of the progression when you do this. And that's as opposed to, 5, 10% of people who are on, normal, existing therapies. And the other thing to know is that the thing about the stem cell therapy, and I find this is the last piece of evidence, very compelling, is that you actually, if you stop the inflammation, 50% of people at 1 to 3 years will have improvement in their disability. So they get back function that was lost. This progression, which is, some people think it underlies everything, this neuronal death of these cells. It's not that simple because they restore function in 50% of people with this. And when we did this at Hopkins, we saw 40% reduction in disability at 23 months in the patients who we gave high-dose cyclophosphamide to. So What I would say in closing is that to me, this is very compelling. If you really do shut down the inflammation completely with stem cell transplants, I mean, we have all of the evidence of we're doing so much better in many respects, but if you completely shut it down, you effectively stop this progression. That cannot be, to me, I'm happy to hear from other people, but that cannot be that this is two separate diseases. You just can't shut down the separate disease by, some degenerative disease, some Alzheimer's-like disease, by shutting down inflammation. That means it's the inflammation is underlying it. And that's what we're working on, is to come up with new ways of addressing this. And I just think that the good news is what you do today will impact what happens to you tomorrow. Even, even now, smoking, don't do it, obesity. Now, if you look at me, do as I say, not as I do. But in any case, what you do, and as my colleagues like Dr. Yadav has mentioned, all of the things you can do to take care of yourself, exercise, watch what you eat, and this kind of stuff, it makes a difference. Not necessarily now, but down the road, that you can really make a difference. So thanks.
Thank you, Dr. Kaplan. And now for the fun part. We're going to start answering some questions here. So first questions to answer, Dr. Emmanuel Waban.
Okay, so some of the questions were kind of answered by our little statement about our particular topic, but I'll just take some of the questions that were not addressed. So one of the question actually I think was addressed, but maybe we were not clear about that. What's BTK inhibitor? So it stands for Bruton tyrosine kinase inhibitor. So it's a medication that inhibits that enzyme, which is very important in some of the white blood cells that are typically not targeted by the treatments that are currently on the market. And you've heard about their benefit in progressive MS and their very marginal benefit in preventing relapses. That's why they are not looking better than what's on the market, and that's why probably they will not be developed towards relapsing remitting MS. The other question is so there was a question about breakthrough for people with secondary progressive MS. So we've discussed that, but the question was about for someone who has already taken 2 years of Mavenclad. So Mavenclad is a fairly immunosuppressive medication, and we can switch from one medication to another, but we have to respect what we know that medication was doing to the immune system to make sure we're safe in terms of decreasing the risk of infections, for example. So if you were on Mavenclad and there was a discussion to switch to another medication afterwards, your doctor should know how long to wait to actually switch to the next treatment you may consider. Again, the new breakthrough for progressive MS will probably be in the next year, the approval by the FDA of one of the BTK inhibitors. So relating to progressive or secondary progressive MS, question is, I would love to hear more about PIRA. So PIRA is something called progression independent from relapse activity, and its correlation with GFAP, so GFAP levels. So these are two very separate questions. In the past few years, there's a new concept that has emerged, which is not something we see in every patient with relapsing remitting MS. There's some data suggesting that some patients who have relapsing remitting MS, even outside of a relapse, may accumulate very slowly some level of changes on their examination, whether it's a little bit of more weakness, a little bit of additional changes in the sensation or in their balance. And that has been named PIRA because disease progression that seems to be not related to residual symptoms that come from a relapse. There's really a fair amount of thinking that this may be actually the very early stages of secondary and progressive MS before patients can even detect it. So there's probably some overlap between PIRA and progressive MS, but maybe in some patients there's not. So we're paying attention to that. Clinical trials are also paying attention to that because it may be some sign that the medication patients are on is not as effective as we'd like it to be. That is for PIRA, and I will finish with my last question. What are different treatment for MS? Limited walking, it seems to hurt. So there's first, the thing is to try to slow down the progress of inflammation and disability. So these are the treatments we've discussed, like for patients who have progressive MS, the main medication that is currently used is Ocrevus. Occasionally, people also use some of the S1P modulators like siponimod, ozanimod, and so on, but it's unclear they are as effective in progressive MS. But then there's all the medications that treat the symptoms of difficulty walking. So there's some devices like Bioness or the Sionic sleeve that can be helpful in terms of helping muscles to contract when there's weakness in a leg that slows down walking. But there's also medication like dalfampridine or Ampyra that may help also to conduct the nerve information faster along the nerve cells. And then there's, for some patients, the difficulty walking is due to spasticity, so increased tone in the muscles. And there's a couple of medications out that can help reduce, to some extent, the stiffness and can help in walking better. So this is it for my questions. Thank you.
Dr. Majid, do you have any questions?
So aspartame use in MS. I think Dr. Yadav know more, but I don't think there's any data on aspartame and MS, but we usually don't recommend using artificials, and byproduct of aspartame, maybe not aspartame itself, but byproduct of aspartame can be useful to nervous system in general. So there's no recommendation about that. Don't recommend usually using aspartame.
Dr. Hapler.
Thank you, Claudia. Well, I had 3 questions. First, a simple one. Are patients with MS more susceptible to Alzheimer's disease? It's a fascinating question. Of course, patients with MS can have cognitive problems, but there was a recent study from WashU suggesting, thank you, that patients with MS have less in the way of amyloid plaques. Now, why would that be? Probably because the microglia, which are scavenger cells in the brain, are more active, and they're engulfing the amyloid plaque, but there's about a 50% decrease. I wouldn't suggest MS as a treatment for Alzheimer's disease, but you're less likely to get it. So, yeah, there's some goodness, yes. I keep forgetting that, though. So question about the research regarding genetics pertains to MS. So, as was alluded to earlier, the International MS Genetics Consortium was in part formed out of investigators here from Nancy Davis, and we've discovered 233 common genetic variants which put you at risk for MS. Now, these variants are basically in immune cells, predominantly in immune cells. They lead to a lower threshold. It's easier to activate your immune system. So is that bad? Well, actually, it's good. It fights off cancer, fights off viruses, but too much of a good thing can become a bad thing. And again, these genetic variants are shared among different autoimmune diseases, but half the MS genetic variants are in other autoimmune diseases. And if you have MS, you have about a 4 or 5% chance of developing inflammatory bowel disease, Crohn's or colitis. So there is that linkage. But what is new, the paper we published last year in Nature, was discovery that there are other genetic variants associated with progression. And these variants are not in the immune system, but more in brain cells. And so there are different genetic variations associated with worsening progression of disease, as opposed to genetic variants that are associated with risk of developing the disease. And again, as Rhonda mentioned, the question comes up, well, if it's genetic disease, should I have children? And I go, yeah, absolutely, because everyone's genetic risk for something, right? You may not know what it is, but we're all at risk for something. And the odds of developing MS in your children are slightly increased, but still the odds of developing MS are still very, very low. So that's kind of where we are. And again, I would point out that I don't like the use of the word stem cell because it's bone marrow transplant. Remember that. And just getting back to MSAD, biggest question in the disease, if you treat early, do you prevent secondary progressive disease? We don't know the answer to that. But I know that compared to the 1970s, when I started seeing patients where the waiting room was full of wheelchairs, we're doing much better now. But it will take 20 years to know if treatment with B-cell depletion is preventing progression. But one thing is clear, very clear. The earlier you start treatment, the better the outcome. Every clinical trial has found that. And we end with someone's wondering when there'll be some kind of cure for MS. So let me just throw down the gauntlet. If you have a drug that stops the disease 98% of the time, i.e. B-cell depletion, is that a cure? Yeah, well, we don't know. It's a genetic disease, and it'll be a lifetime. I think the word cure isn't interesting, and we need to look at it as a relapse-free without progression. But we've made big advances in the treatment, and I think a subset of patients who go on early B-cell depletion, which turns out to be a very benign drug, much more so than we thought it would be. 10 years out, I mean, patients still doing well, no side effects. And in fact, I would just end with saying MS clinic has become much more boring, and I love it. Patients used to come in, Peter, remember this? How you doing? I'm on Copaxone. I get injections. I'm having attacks. Look at the MRI. Doing well. Interferons. They come in now. How you doing? Great. Any problems? No. Side effects? No. I feel bad billing them. We still do, but still, I won't get. But we probably should, but don't tell the hospital that. But it really has been a remarkable change in the treatment of the disease. And maybe one other immunologic, what would come after B-cell depletion? Right now, we're depleting all of the B cells expressing CD20. I'd like to develop antibodies that are more specific to subsets of B cells. So we're not depleting all the B cells, and that's something we're intensively working on. So I'll stop there.
She wants to ask you a question.
Oh, sure, yeah. Oh, yeah, yeah. Well, the data is looking at brains of patients who have MS and looking at amyloid plaques. So the data seems to suggest that if you have MS, you're less likely to develop, not dementia, because a lot of causes of dementia, vascular dementia, MS can cause dementia. So I'm not saying you have a lower instance of dementia, but there appears to be a lower instance of Alzheimer's disease, which is a very specific disease caused by amyloid plaques.
And then the other question I had quickly, whoever's could answer it, is on the diet situation. Is there, the reason I asked, my mom has MS, and a lot of my friends have MS. They seem to be, at least my group, seem to be allergic. My mom was allergic to anything from a cow, milk and dairy, and my other friends have too. Oh, sorry, that's okay. Is there a specific diet? Is that normal? Because my 5 or 6 friends that I have all are allergic to dairy and cow stuff.
I don't think there's any evidence that allergies to cow products associated. From my perspective, everyone in this room, whether you have MS or not, should exercise, have a low-fat, low-salt diet. Full stop. Whether it changed the course of MS is really hard to know. I mean, we know that salt, for example, it really induces inflammation quite a bit. So should you be in a low salt diet? Of course you should. But how many here who are over 40 have hypertension because of the high salt diet in the Western diet? So everyone should be on a no processed foods. So yeah, we all should. Whether it helps MS or not, hard to know.
Thank
Thank you, Dr. Hapler. And also concerning diet questions, I think Dr. Yadav can be helpful too. Mhm.
Well, the genes get diluted out. But I never heard that either.
We can't hear actually. Can you turn the mic on?
She's asking to explain the BTK.
And may I ask something else? Sometimes with people with MS, they was accustomed to having a good life and able to do everything on their own. And now it has happened where they have a lapse where they're not unable to do the things that they are. And they're seem like they get agitated or very anxious. Do you think at that point, the primary doctor maybe should recommend that they see a psychologist or something like that?
I see your question, thank you for bringing it up. That turns out 50% of people with MS at some point after the diagnosis will have a clinical depression. Anxiety comes along with it. It can be independent. We don't know as much about anxiety and MS, but we know a tremendous amount about depression. It's not your fault. It's not a weakness. It's due to the inflammation in the brain. MS causes the depression. If you block the inflammation, so natalizumab Tysabri is the treatment that really does prevent the immune cells from getting into the brain. They don't have the key to unlock the door to get in, and it turns out it will treat people with depression who have MS. Because when you block the inflammation, you improve that. What's also interesting is that, and this goes to another question that I got, every single antidepressant, every single study that we've done looking at things that treat depression are all anti-inflammatory. So if you take randomized study and you put, people who have MS and not depressed on an SSRI like Prozac for a placebo, over time, you'll have half as many new lesions in those patients. Now, there are side effects with every medicine, so I don't recommend just going out and going on Prozac. It's not that simple, but these are all anti-inflammatory. Psilocybin is another drug that turns out to work for depression, and it is anti-inflammatory. Ketamine, the most recent addition to the armamentarium. These are all things. So inflammation is important, and it's also important to know that even if you don't have MS, for those people who are caregivers and the like, it matters if you get depressed. Depression turns out to be a risk factor for getting autoimmune diseases. You're twice as likely to get MS if you have a depression, twice as likely to get rheumatoid arthritis, lupus, and inflammatory bowel disease, not if you get treated. If you treat the depression, that risk comes down, and that's because there's a close relationship between the depression and inflammation, and the two, it's pouring gasoline on a fire. So the short answer is that all of the doctors here know how to treat all of the symptoms that patients get. They don't say, oh, you're in pain, you got to go see somebody else. They take a first pass, and they will try, based on their experience and largely what they've learned from studies is about a third of it. The 2/3 is what they've learned from you and other patients. And so they will treat it. In fact, Dr. Voskel was just talking to me last night about all of the patients that she takes care of, the above the neck symptoms like anxiety and depression and the like. But if that person tries you on a medication and it doesn't work and you're not getting better, or especially if you got worse, because there are some conditions that look like depression and it actually gets worse with antidepressants, then you should go see a specialist, absolutely. And so I think that's a critical aspect. Let me just, because I could finish up here just with the last question, which is how important is it to keep busy with something that makes you feel worthwhile, keeps you from being depressed? And this gets to something that's near and dear to my heart, which is purpose in life. Having the belief that your life has a purpose. This goes back to Viktor Frankl and Man's Search for Meaning. But having a belief that your life has purpose makes you 2.5 times less likely to progress to Alzheimer's disease. So it's good for the brain. It makes you 3 times less likely of dying from all causes over the age of 50. Now that I'm over the age of 50, it's very important to me to be aware of this. And so it turns out it's actually good for our health to make sure we do have something. And sometimes with MS, that means giving up the old goals because you can't do the old goals. So Claudia is, an excellent example of this, that she can't do the polo that she started years ago, but she teaches horseback riding. I mean, that's incredible. A woman who, uses assisted devices to get around walking significant distances and the like, but she doesn't give up her purpose. Her purpose is to, continue to help people learn and to see how you can struggle. And I don't know how Nancy does it. She's 24/7 working on trying to help people with various ailments. And she is, not only not given up, sort of doubled down on helping every single person in the room. So I think it's just very important that you make sure you understand that having something that will engage you is important to find. So that's it. Thanks.
I think this is for Dr. Hafler. Can you explain why 4 to 5% of people with MS are more likely to get IBS and Crohn's, and if gut issues are a precursor to getting MS?
Fantastic question. So the reason why is because of the genetics. When we've looked at, there's a paper we published back in about 6-7 years ago. We looked at genetics of the different autoimmune diseases and said, where is there overlap? And it turns out the 3 diseases that had the most overlap with MS genetic variants are celiac, Crohn's disease, and ulcerative colitis. So there's a genetic basis for it. Now, the question about the gut is an incredibly interesting one. It looks like all the T cells going to the brain are coming from the gut. Even during development, looking in mice, we've discovered that T cells are being driven by the gut bacteria at about the time of weaning and go from the gut to the brain just normally and involved in brain development. A recent study by my colleague Vijay Kutru at Harvard showed that in the animal model of MS, all the T cells going to the brain are coming from the gut. And we're just beginning to explore that. We actually, a grant that we have from the center is to do gut biopsies on patients with MS, look at the T cells in the gut and see how they look like the spinal fluid. So I had a spinal tap, and we looked at the T cells in my spinal fluid, and many of them had the same receptor as in the gut biopsies that I had. So it looks like there's a gut-brain interaction, which is really, really interesting. We're just beginning to explore it. And it gets back to the comment made earlier about the microbiome, which is driving T cells to go into the nervous system. So a lot there, and something we're really working on. There's another question which I just got, which maybe just I can answer, which is a great question. Is genetic testing possible to identify persons with the genetic makeup required for MS? That's before someone gets MS. So we're just beginning a study. Aaron Longbreak in our center is going to lead it, where we're going to take children of patients with MS and measure their genetic, we call the polygenetic risk score. And those individuals who are normal, parents have MS, if they are in the upper quartile, the risk of MS becomes more significant. If they're in the lower quartile of risk score, they won't develop MS. So we're going to start doing that, and we want to get blood from the patients every 6 months in patients who haven't had Epstein-Barr virus. And then as the patients develop MS, and some will, we can watch the progression of being normal to developing the disease. So we're going to use genetics as a way of identifying populations to do that. So it's a terrific question. So we're just starting to incorporate genetic testing at Yale in the care of our patients.
Thank you, Dr. Hafler. And for time's sake, we're going to finish answering the questions that have already been submitted, and that perhaps may answer some of your questions. And after we've done that, then please submit your questions. So it's the lightning round. We're on a lightning round of answering questions. So next, Dr. Yadav, would you like to?
Yes, thank you. So I think continuing this story on the diet, and if the question is there a special diet or foods that patients should take or stay away from? And so right now, there's no one diet that can be recommended for patients. The studies which have been done using diet, they have included low-fat diet, very low-fat diet, Mediterranean diet, then Wall's diet, which is a paleo type of diet. All of them, the common theme among all of those diets are they're all recommending do not consume processed food, and then eat lots of vegetables and fruits and like good protein, good, I mean, it can include animal products, but it has to be lean meat, preferably. Some of the diets they recommend avoid red meat, which I think could probably make sense from the cardiovascular perspective. There's from the cardiovascular disease prevention perspective, red meat definitely I think has been related to higher risk of cardiovascular disease. So I think maybe that can be kept in perspective. But there's no one diet at this time. And if you consume fat, it has to be a good quality, even if you take saturated fat, it should be high quality saturated fat, which has high omega-3 fatty acid content. Then in terms of staying away from gluten or dairy, again, there's no clear-cut connection between gluten or dairy at this point. There are people who have celiac disease or they have gluten insensitivity. Definitely, they should stay away from gluten. But in general, it's not avoided, or it doesn't have to be avoided. Same thing is true for dairy as well. There's no connection at this point that dairy is bad for MS or dairy is bad for immune system. So if you cannot tolerate, because there are people who are lactose intolerant, so they will not be able to handle dairy products. So they should avoid. Otherwise, in general, there's no need to avoid that. And then the diet connection with the vascular disease is very strong. I mean, people who eat poorly will have heart disease, cardiovascular disease, hypertension, obesity. All of these diseases are clearly now known to affect MS adversely. So I think healthy diet is really, really important for everybody and MS people in general. Second question was about the lipoic acid. What is the dose? And before I say about the dose and all, I would say the clinical trial that have been completed recently, they tested 1200 milligram it can be taken with food, usually in the morning. However, there were cases of autoimmune kidney disease in these trials. So I think the risk of autoimmune kidney disease is anywhere from 1 in 50 to 1 in 100 or maybe higher. So I think one has to be careful. Do not take the supplement just because it is over-the-counter available. These supplements can cause damage. So it has to be taken under the supervision of the doctors. You should have, or whoever is taking lipoic acid. And it doesn't matter low dose, high dose. Anybody is at risk of developing these autoimmune kidney disease at least. So they should have kidney function tested as well as urine tested for protein at least every 6 months. And that's why I think any supplement should be taken under doctor's supervision. I think that's all.
Thank you, Dr. Yadav. And Dr. Calabrese.
Okay, there's a question about using the diagnostic criteria and why does it have to involve the brain and spinal cord? And so actually it doesn't. All we require is that there be dissemination in space in 2 of 5 typical categories. And so I mentioned the optic nerve is the 5th one. The other areas that we think of as typical are the periventricular, the fluid-filled cavities in the center of the brain called the ventricles. If you have lesions that are adjacent and perpendicular to the ventricles, that's one classic location. Lesions in the brainstem or cerebellum, the bottom of the brain, is another classical location. Lesions that are at the gray-white matter border, what we call juxtacortical, are also typical. And then spinal cord. If you have just brain lesions, you can make a diagnosis of MS. More rarely, but sometimes we see people with multiple spinal cord lesions, and you can actually make a diagnosis there if someone has oligoclonal bands, and especially in primary progressive if they're continuing to progress. There are several questions about discontinuing therapy, and I think this is a really important topic. And one person said, why are people even thinking about stopping therapy at age 60? And that's a good question. I think 70 is the new 60, especially for me. There was a notion that as we get older, our immune systems become less active or competent. And there's some data around that. That's why CDC recommends after age 65 getting a double dose flu vaccine, because older people might need more of a boost to mount an immune response. However, in my experience, I've seen people stop therapy in their 60s and have reactivation. There was a small clinical trial done in folks who'd been on Copaxone. It's called DISCO-MS, for discontinue Copaxone. And what they found in that study was that the people who stayed on Copaxone had about a 5% risk of any kind of new activity, either clinically or on the MRI. The people who stopped Copaxone had a 12.5% risk. And so absolute difference of 7.5%. Some people look at that data and say, I'm taking all these Copaxone shots and that's all I'm getting from it. And other people say, well, I don't want to take the 7.5% risk. I'm more in the camp that I tend to not stop therapy in people's 60s. I think you have to individualize. This is the art of medicine. Just if you have someone who's really not tolerating the therapy very well or having a lot of infections, then you might consider doing that. However, if someone's just doing great and they don't mind the shots, people 75 who still take injections because they've never had anything since they started. So this leads to another question about discontinuing the high efficacy therapies like Ocrevus, especially in the setting of infection. So unfortunately, as people stay longer on B-cell depletion, we do start to see infections, especially viral infections. There was a study from the Scandinavian countries where they showed that after 4 years, the risk of a moderate or severe infection goes up to 40%. It's a little higher than what I feel like I see clinically, but certainly infections are an issue. However, you have to kind of weigh that, is it really the drug or not? Because we see infections in people with MS. Otherwise, especially if you're in a wheelchair, you might be susceptible to skin breakdown. People with bad spinal cord MS will have what we call a neurogenic bladder, where they can't empty the bladder, and that leads to colonization with bacteria. And so there are lots of reasons why people with MS get infections independent of the drugs, but the drugs certainly add to the risk. I do sometimes start trying to space out the dosing interval of the anti-CD20s. I think sometimes that can be useful. And it's not super risky to stop them because B-cell depletion results in a long-acting, long-standing kind of B-cell depletion. It takes often a year or more for the B-cells to come back, whereas the drugs that we call cell trafficking agents like natalizumab, which is Tysabri, or the sphingosine 1-phosphate receptor agonists like Gilenya, fingolimod. Those drugs actually are risky to cold turkey stop because they work by trapping the cells in the lymph node or bloodstream, and then if you stop them, you can open the floodgates. Whereas the B-cell depletion, you have to reconstitute new B-cells from the bone marrow, and that takes a long time. So hopefully that's helpful. There are lots of nuances, and I encourage you to talk to your doctor about the details of your particular situation. Thank you.
Thank you, Dr. Calabrese. So next, Dr. Bosco, I think you have some questions to answer.
Yes, and one of my first questions is a direct extension of what Dr. Calabrese just said, and I just have a little bit to add. I agree with everything he said. Would you recommend patients on Ocrevus continue their treatment even after transitioning from RR to SPMS? And while he brought up a lot of points about, risk to infections and so forth, I think of it as, this question that was brought up before, is MS inflammatory or is it neurodegenerative, or how they're related? And it's both. Unlike politics, it's just both. And it can, and a lot of people do the inflammation does cause it, and you get degeneration second to the inflammation. But then it's also true that the neurodegeneration can take on a life of its own. And we know that because you can have complete loss of no new lesions, and you can still have progression. So it's both. And that's important to this question about whether to stop Ocrevus, which will shut down, really well, new relapses new enhancing lesions. But, you know, what I said, you can still have this ongoing neurodegenerative process that becomes somewhat independent. It started it, but it kind of can take on a life of its own. And so, you know, stopping Ocrevus, I think you need to think very hard about that, because if you stop it, I don't think it's a great idea. I think that if you do it, you really should at least get an MRI in 6 months. You don't know what you would be doing if you didn't have it until you don't have it, and so I wouldn't wait till you had a relapse or real worsening. I think we would monitor very closely that it may have controlled you so well you think you're doing great, but when you take it away, and so I would do really close monitoring with MRI to see if the lesions come back, maybe even in 6 months when it's worn off. So the other question that I had is again going back to this neurodegenerative process and having very little this neuroprotective. So ideally you would take this anti-inflammatory and then you would take another neuroprotective. And the estrogen, I was asked if increased estrogen improves cognitive function, should female patients be taking additional estrogen? And I like the word additional because first of all, it would be used as a neuropreparative in addition to something, a good anti-inflammatory, not to replace it. The other thing is we have several papers, the last of which we showed that when we gave estrogen, estriol, not estradiol, at a pregnancy dose, that we reduced serum neurofilament light chain in the blood, which was a biomarker for neurodegeneration and disease activity. We showed that we slowed cortical atrophy at 1 year, and we showed that there was an improvement in cognition, not just a slowing of worsening, but an improvement, which gets back to how estrogens can increase synaptic plasticity and remyelination. So there is hope there, but again, it's phase 2 trials. It hasn't gone to the point of phase 3s and FDA approvals. I do want to caution that the estrogens are not all alike, and that gets to the last question, and that is if you have breast cancer and have MS, is it okay to take estrogen therapy? The answer is no, absolutely not. Breast cancer is driven in large part, it's very common, and estrogen receptor alpha is in breast, and people take tamoxifen for the very reason of blocking estrogen receptor alpha. I wouldn't give healthy people estradiol if they had breast cancer. I wouldn't give MS people estrogen if they had breast cancer, and for sure not estradiol, which binds the ER alpha strongly in the breast. Now, different question, a gradation is, would you give estriol, because it doesn't bind ER alpha strongly, it binds ER beta in the brain to confer neuroprotection. I wouldn't even do that because estriol binds ER alpha a little bit, but it is a thing to think about, because the estrogen receptor alpha and beta can be synergistic in some tissues and antagonistic in others. And I talked to a very big guy at UCLA who's invented Herceptin for breast cancer, and I said, could ER beta be used to counteract ER alpha? And he said it could, but it depends on the cell. There are different cells that cause breast cancer even. Breast cancer is driven by different cell types. So I wouldn't do it. Would I give estriol to somebody who has a family history of breast cancer? Yeah, I probably would, because it doesn't bind ER alpha strongly, and they don't have breast cancer, and they have a family history. But that's not really an exclusion, just to have a family history of a disease. So that's the gradation of that. Yeah, and I just think it's very important to think about estradiol, which is the menstrual cycle estrogen that binds ER alpha strongly, versus estriol, which is the pregnancy estrogen that binds ER beta for neuroprotection, but not alpha. But breast cancer is really a problem, and I would stay away from it completely if it had a breast cancer. And first-degree relatives, I wouldn't take estradiol either, had a first-degree relative with breast cancer, but that's me being very cautious and do no harm. So,
Thank you, Dr. Bosco. Dr. Kaplan, do you have any questions that you haven't answered? I'm sorry.
I'm gonna butt in, Claudia, and take my spot.
The most important, Dr. Sykott.
Thank you. So great questions. I just have 3 of them. One is, does the radiology facility need to have the latest technology in order to be able to detect pearl lesions? So it's a very sophisticated question. And the answer is no, but yes. So the reason is that the kind of sequence we use is called a susceptibility weighted image, and that's kind of standard on MRI machines now. But there's some subtlety to that, and this is something we're working very hard on. So again, the many steps to get this, new scientific information, but to actually bring it to patients and this, translating the work that we've been doing into patient care is challenging because we're neurologists and researchers, but the radiologists are the ones who actually have to implement these changes. And so we're working hard to do education and also with the MRI companies that make the machines and make the sequences to get these kinds of sequences put in, and doing some modifications. Pascal Satie, who's worked a lot on this, has a really nifty susceptibility weighted image protocol that has a slight change to it that allows the pearls to be seen really well. And so then we have to teach the neuroradiologist to recognize them and report them. So stay tuned. There's still work to be done, but that's a very sophisticated question. So here's another good one. Will an MRI detect if you progress from relapsing remitting to secondary progressive if you have no relapses ever, but you see progression of your disability? And so the answer to that is really no. We do see things that are associated with developing progressive disease. One of them is pearls, as I said. When we tend to see people who have progression to have either a lot of spinal cord lesions, a lot of atrophy in their brain, maybe a lot of white matter changes. But the truth is, diagnosing the progressive form of the disease is a clinical diagnosis, which means your neurologist has to see you and monitor you, and the research definitions are over a year. We have to see worsening of function, and we use the EDSS scale, which is a walking scale, to help us with that, or timed walk. So it's really a clinical diagnosis, and this is frustrating, I think. And people can have progression in other systems. We talked about cognition a little bit. People can be worsening even though some of the usual things that we test when you come to the clinic don't seem to be changing that much. So I really listen to the patients, and because the patients know what they're dealing with each day, and the question I'll ask is, if you think about 6 months ago and now, what's different? And that is usually a pretty sensitive indicator, but it's a clinical diagnosis, and we're still looking for the best biomarkers for that. We talked a little bit about GFAP and NFL. There are these blood biomarkers that may help us. This one, there's a question about when will there be studies on specific patient groups who have progression using the 7T. And I'll just point to our USC colleagues. We actually have a collaboration now starting where we're going to be doing some of this work on these new biomarkers on the 7T that's over at USC, as well as 1.5 and 3T. So we're really trying to harmonize these new techniques to use across field strengths. So another example of the collaboration within the NAMES cooperative. And then the last one was, does amitriptyline cause brain atrophy? I have never heard that as a direct cause. Amitriptyline has anticholinergic properties, which means like it makes your mouth dry, makes you sleepy, makes it harder to go to the bathroom, but it's also associated with some worsening cognition. So we tend to avoid it in people who have memory problems. So I don't know if that's where that came, but I'll ask my other colleagues. Has anyone ever heard of amitriptyline causing brain atrophy? No. Good. Glad to know that I didn't miss something. Thank you.
Thank you, Dr. Sykott. Dr. Wabot, I think, has the last question.
Yes, so I have a last question to address quickly. Ocrevus and some other MS drugs have reduced efficacy with vaccines. Do we have additional info on the level of protection MS patients can receive from the COVID vaccine? So patients with MS on no treatment respond as the general population to vaccines in general. So there's no worry about that. Now there's different categories of medications for MS, like anti-CD20, so that would include rituximab, Ocrevus, Briumvi, Kesimpta, that decrease the efficacy of vaccines, especially if people have been for a long time on those treatments and then they do a vaccine. So what we recommend before starting these treatments is often to do vaccines that like shingles or pneumococcus, that are vaccines that you don't need to repeat every year. So we try to do that a couple of months before, or at least a month before you start treatment. Once you're on these treatments for the vaccines that need to be administered, then we try to change a little bit this, either we change the schedule of the treatment to try to have 3 to 4 months after an injection, if it's the every 6 months treatment. We wait after an infusion, about 4 months to do the vaccine, and then 1 month before the next treatment. So it's easy with the every 6 months treatment. That may increase the effectiveness of the vaccine. But if you've been on these drugs for a long time, maybe the improvement is mild. For people on Kesimpta, then I sometimes have my patients keep a couple of injections to actually try to have maybe a better response to vaccines.
I would just add that the antibody response is decreased, but the T cell response to the vaccine is increased with anti-CD20 treatment. Now, 2 studies ourselves and Bar Orbo show that. It's interesting.
Okay, we also have one more question over there.
Yeah,
Sorry.
we came a little late, but I had submitted a question. Friend Roland here is considering stem cell treatment, but he has to travel outside the country to receive it. And from some of the discussions, the donors seem to be either from young adults where they, I assume, harvest from their bone marrow, but also some have talked about placental stem cells. And then also, we want to understand the risk and efficacy of those therapies, and then also the difference between using those stem cells and your own stem cells and harvesting those and replacing that. Are all stem cells the same, or are they different? And what's the treatments going on with
So
them?
you have to separate bone marrow transplant, where you get a toxic dose of chemotherapy and you get transplantation of your own blood cells from the bone marrow.
Right.
It's an incredibly effective treatment, but we're not sure it's any better than just Ocrevus or Cytoxan. There are other forms of, which are probably not real. Where you're not going to grow back brain by injecting placental cells. Let's put it that way. I think going out the country, I think P.T. Barnum said it best.
Okay.
So but it's a discussion with your own neurologist saying exactly what it is.
Right.
What are they actually doing? But again, stem cell in terms of regrowing brain as opposed to really getting bone marrow transplant, which really does work.
It's
but
really
very
bone marrow
toxic.
transplant. That's how you class
We
it.
confuse those terms.
Right.
And I think we have to differentiate them.
And you don't have to leave the country. There's things like that locally.
There's a NIH-funded transplant trial right now, autologous stem cell transplant going on right now, which I think you can go to the website. It's called BEAT.
Bone marrow transplant or?
No, it is, it's a bone marrow transplant.
It's bone marrow.
It's autologous stem cell transplant, correct.
I think they're talking about something different.
Right, but I think none of the other transplants are worthy of doing, because at least in our experience, they have not really shown to be beneficial at all. So the only thing that you should be considering would, if it's also for relapsing MS or refractory MS, would be the stem cell transplant, which is autologous bone marrow transplant.
Yeah.
So for that, Beat MS is the website. You should look into that.
Where that's available?
Beat MS.
So there is another approach that people probably have heard about called mesenchymal stem cell transplants, and this is where they use a different kind of cells that are supposed to be reparative. And there's a company called Neurogenesis, and they've done work in Israel, and they're actually working toward a phase 2 study in the U.S. And in Europe, yeah. So I think a lot of us are skeptical, I will say, because some of the claims were kind of overstated based on the data. But the study that's being designed in the U.S. and Europe will actually answer that question about whether mesenchymal stem cells can be beneficial. But the study itself involves having a bone marrow donation. So you're using your own bone marrow, but that's an operation that has to be done. And then the cells are delivered into the spinal fluid, so intrathecally. So you have, it's having a reverse lumbar puncture. So it's not for the faint-hearted, but for people with progressive disease. Some of them are signing up for that potentially. I think this study design, which will have a control, will answer that question. But I think many of us are a little bit skeptical about, especially the claims that have been made about reversing disability and so on.
So I wanted to add to that. I think it seems kind of confusing, but if you think about how these things work, like was said, you have to find out what they're doing. So on the one hand, if it's going to be resetting the immune system, and then maybe you get a little bit of improvement in the brain because of some naturally occurring reparative things in the absence of the ongoing inflammation. That's one thing. And that could be promising, just to have a reset of the immune system by the bone marrow transplant. But when you start, as a neuroscientist, I'm just saying, when you start talking about, injecting a stem cell that's supposed to become a neuron or an oligodendrocyte or some of these other things, you're injecting it into the spinal fluid. It's still got to go from the spinal fluid, and it's got to go into the brain, and it's got to go into these lesions where things are happening deep into the brain. I don't see any way that's going to happen. If these cells are supposed to go in there and secrete something in the spinal fluid, they're going to have to hang around a long time to continue to cause repair if there's something soluble. I can just tell they're not going to go in there and get in there and stay and live and integrate the axon. I'm like a nerve, and this is my axon, and this is my synapse, and then I've got oligodendrocytes wrapping myelin. Now, how is the cell going in the fluid outside there going to even get into this compartment? And when it does, it's going to migrate all the way over to here, and it's going to make myelin. I don't see how that happens at all. You can't even do it in mice. And so that's my skepticism of imagining. And they won't survive either. Your body's going to get rid of them. They're not going to get to the target. And in MS, it's a multifocal disease. The place to do it is spinal cord injury or Parkinson's disease, really spinal cord injury. You got one spot, one place. You inject them not in the spinal fluid. You would put them right into the lesion. Let's see if they work there, and we get great results there. But to think you're going to put them in the spinal fluid around the brain, and they're going to somehow get to these multifocal lesions that are coming and going all the time, is kind of like unrealistic. That's my opinion.
Sorry, Litma. I just wanted to clarify what I said about those two patients. Also, it was bone marrow transplant. That when I was in WashU, we had two young females that had very aggressive MS with B-cell depletion. We couldn't control the disease. Again, we checked for every other disease that we could think of, including even genetic diseases. We didn't find any treatment, and we just sent them to NIH even before the BEAT-MS trial, and they tried hematologous bone marrow transplant, and I know one of them responded well. The other one, I don't know if she responded or not, but for one of them, we know that the response was better than the B cells in that patient.
But again, wouldn't that be resetting the immune system? And then if there's some natural repair, that's okay. But it's resetting the immune system. Isn't that the strategy, the mechanism thought to?
Probably, okay. But yeah, I'm not sure about that.
Yeah, I think we're differentiating, and this is the confusion. There are multiple kinds of stem cells, so we're differentiating the bone marrow transplant, which is the hematopoietic stem cells, versus mesenchymal stem cells, which is a different kind. And what we're saying in the BEAT-MS trial, which is doing this hematopoietic stem cell transplant, in which there's papers and recommendations you can read about, does have a role, but it's a small role in very rare patients of very active disease. And the mesenchymal stem cells is something that is still very experimental, very potentially problematic, but there is a study that's going to go on that will answer that question. And then I guess finally the third kind, which is putting in cells that are going to make new myelin, oligodendrocyte precursor cells or something like that, is, as Dr. Voskuil is implying, very difficult to imagine and not been realized for patients yet. So I have my little spiel about 3 different kinds of stem cells, and it's very, very confusing for patients. Anyway.
So actually, OHSU is a site for transplant, the BEAT-MS, and we have done 2 transplants so far as part of that.
Thank you, doctors. And we're going to conclude our program now. And in conclusion, I'm going to let Nancy sign us off. Thank you.
Thank you, Claudia. Thank you to all the brilliant doctors here. It's fascinating. There's always something so new to learn, and no matter what, I think I know so much about MS. When I come here, I learn 10 million new things and new thoughts and ideas, and I think that's been kind of what's so great about this group is it fosters new research and new ideas and new things. And your questions are brilliant and very thought-provoking. Thank you, everybody, for always supporting Race to Erase MS. We're going to have our 32nd Race to Erase MS coming up on May 16th in Los Angeles. And if you want to come, look on our website, erasems.org. We'd love to have everybody participate, come, or donate in any possible way, because we need to raise lots of funds to, come up with even better research so we will find a cure. So it's our dream that one day in the very near future,